Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SICA, where we partner with healthcare professionals and clinicians to offer body composition solutions. Today, I'm really excited to be joined by Dr. Marc-Andre Cornier. He's the current president of the Obesity Society, and he's the director of the Division of Endocrinology, Diabetes, and Metabolic Diseases at the Medical University of South Carolina, where I worked for 18 years. And so I'm happy that you're able to join me today, though I guess we could have met for coffee to do this as well. We're both in Charleston, South Carolina. So thanks.
Great. Well, thanks for having me, Nina. It's a pleasure and excited to chat with you.
Yeah, well, I think, one of the big things I've been talking about a lot lately in the new year is about this Lancet Commission report. And so I've talked with a lot of different folks in the different obesity groups. And so I thought, given your role with the Obesity Society, you might be able to share kind of what's going on in your pocket of the world and, maybe the response that TOS is having, what leaders are saying, and maybe even some of the members' responses to the report.
Right.
It's been all over with, some positives, some negatives, some in between. I mean, getting 75 or so people to commit to consensus on obesity diagnosis is definitely a challenge.
Yes. Yes. So, as a society, we were excited and we welcome this publication. We There was some things that we wanted to clarify because people have asked, "Oh, well, you endorsed it." Well, yes and no. We endorsed the commission itself, but we didn't endorse the publication. We were not given an opportunity to review the paper
Hmm.
ahead of time to be able to make changes to it. So
Okay, I get
so
that.
so we didn't know what they were going to conclude, right? So we endorsed bringing the people together, the idea, but we don't quote endorse what they said at the end of the
Okay.
day. And so that's an important distinguishing feature. And we've asked that they clarify that to the public.
Hmm.
I think it's a great starting point. It's a great start for discussion, for more research. I mean, I think we're all in agreement that body mass index by itself is not sufficient for diagnosing obesity. It's great at a population level. It does correlate with excess body fat or adipose tissue, and that's what we care about, right?
Right.
So, on the individual level, it may not, though, right? Obviously, on extreme examples, you have elite athletes who have significant muscle mass. Their BMIs could be in the obesity range if you just used obesity. Yet we know they don't have excess body fat. So now, the majority of people in our country with obesity, their BMI correlates highly to their body
Hmm.
fat. And so, I think for most people it's fine, but there are examples where it's less clear. So the report, suggested that once we screen somebody with body weight and body mass index, that we confirm that they have excess adiposity using either anthropometric marker, that so measuring the waist circumference or using a ratio of waist to hip or waist to height. And that's fine. That's easy to do. But the reality is nobody does it. We've been preaching waist circumference as an important measure of body composition for years and years, and yet almost nobody does it. They also recommend, well, if you can get a direct measurement of body fat, then great. So there's a couple of tools that you can use. DEXA scans, we use those to measure bone density to
Right.
diagnose osteoporosis. Well, you can get, lean mass, which and fat mass. And so, but what's normal and what is associated with increased rate? It's less clear. And who pays for that? No insurance pays for DEXAs for body composition, and it's not a cheap test to do, and not everybody has access. The other is bioelectric impedance
Right.
analysis, or BIA. Well, again, it's what other, there are some cutoffs that they suggest, but what's true obesity based on that? That's less clear. Not everybody has these devices that can be very expensive. So I think it's a great idea. I think
Yeah.
we need more research. And that's what we're saying as a society is this is really good. The other thing that's, I think, kind of controversial is they come up with this new diagnosis called clinical obesity versus obesity, and they call it an illness. They couldn't agree that obesity was a disease,
Preclinical or clinical, right?
no matter what.
Right.
That obesity isn't a disease, and we believe that it is. In the Obesity Society, we've been fighting for this for years to say and raising awareness of obesity as a disease. They're calling it an illness if you have clinical obesity. To have clinical obesity, not only do you have excess body fat, but you have to have a downstream effect from that. So either a complication that's related to obesity or an ability to do daily activities, those kind of things. And then they call, if you have excess body fat, but you don't have any complications, that's preclinical. And that, I think, that especially the pediatric folks really disagree with that, because most children with obesity don't have complications yet. They haven't had it long enough. And so now we're going to call that preclinical. Is that going to limit what treatments they can get? And so I think there's some concerns about that. But again, I think it's a great discussion, great starting point, and we're going to have at our obesity week next year, next November, we're going to have several debates on
Okay.
the
I could
Lancet.
see this leading to some nice debates.
Yeah, and I think again we're all professionals here, and on the commission there was over 50 authors, I believe. You said maybe 70, I can't remember, and a number of them were members of the Obesity Society. Now, they were there as individuals, not as
Right.
representatives of our society. And so, these are all colleagues, and we have to be collegial and just have good conversations. I think that's what we're all about.
Yeah. Well, definitely, interesting thoughts on the pediatric side. I know, in my background with bariatric surgery too, we've really kind of got to the point of early intervention may be associated with better outcomes. So I think,
Right.
that's a question. I know in my work with the OAC, where, we want to make sure that preclinical is not getting turned down from
Correct.
medical or surgical treatment, if that's an impact.
I mean, the folks on the commission, say, well, the goal of their paper was not to talk about treatment.
Right.
And they commented on it that preclinical should still be treated. But the concern of some people are that, well, if you call it pre, then insurers aren't going to pay for treatments.
Yeah.
They're not going to pay for medications if it's not clinical obesity. If it's preclinical, oh, no, we'll wait. And we don't want to wait. We believe that obesity should be treated first. And that's kind of our new narrative, is obesity first. That if you look at charts of patients who have complications of obesity, diabetes, hypertension, cardiovascular disease, only a fraction of those charts will actually list obesity, even when the BMI is clearly over 30, And if it is listed, it's usually the last problem in the note. We believe we need to, one is make the diagnosis in all these people. Just because there's a BMI on the chart doesn't make the diagnosis. You actually have to list the problem before you can address it. And it should come first. We should treat obesity first before we treat all these other things, to treat, prevent these things from happening. Or, if you treat obesity, that improves diabetes significantly, for example. So
I think that's a good point. And, I know with the AMA and discovering, or, kind of classifying obesity as a disease in 2013, that next decade was all about getting people to do that, to put the diagnosis, get that, labeled in their chart. And, they've made some changes to the language around the different codes. But I think that's an interesting, pivot. And I agree, if we don't have the next outcome measure that we are suggesting across the board, it makes it tricky, right? Because are people going to just drop putting BMI at all and then not label it because there's nothing to categorize it as? And for us, at Sika, doing bioimpedance as our business, we've been thinking about and talking about this for a long time. I do think it is within reach for a lot of people that maybe it hadn't been in the past. The technology's gotten a lot better from when we all went to school and kind of learned about bioimpedance 20 plus years ago. I do know that the Lancet Commission seem to focus a lot on what can we recommend that can be sort of globally adopted even in rural areas. So of
Right.
course, the more, complex imaging equipment is not going to be available there. So that part made it a little tricky for me
Well, it's
too.
also a global recommendation, right? So we're talking all over the world, right?
Right.
And so having these technologies is limiting, and that's where just body measurements are easier from that perspective.
Right.
It'd be really nice, ideally in the long run, maybe your company should look at this as biomarkers,
Right.
measurements, like, I mean, certainly you could validate things like leptin or adiponectin as, uh, is associated with insulin resistance. And, so I think there are certainly lots out there that's being investigated. That'd be a little easier maybe, but that requires a blood test, that requires a lab, that costs
Right.
money, so when we're talking global screening, you want to make it as easy as possible.
So what do you kind of see then as next steps, or where do you think folks are going? Because this has been out for a month or so
Yeah,
now. I know things take a long time, but
it is. I have, some clinicians who have come to me and say, oh, should I be, changing how I diagnose obesity in my charts? Should I be saying clinical obesity or preclinical? And I said, well, you can if you want, but there's no ICD-9 code for, you're talking about being practical.
right.
There is no codes for clinical obesity or preclinical obesity. So I think at this point, that's a bit premature. I think next steps are more discussion, more research in this area. There are other guidelines out there and recommendations that have taken BMI and used, for example, comorbidities or complications to stage obesity. There's the
Hmm.
Edmonton staging system. Obesity Canada has that in their guidelines, and the European guidelines also have a system that's somewhat similar. Those make sense to me because you're saying, well, if you have less adiposity, so lower BMI, but you have complications already, maybe we should be calling that obesity. But again, I think at the end of the day, if we could consistently measure adiposity with other methods, and we said it's reliable, I think there's uh, consistently during the weight loss trajectory when we know there's changes in the body and body water and other things.
Hmm.
We and there's the cost is not prohibitive for practices all over the country and the world to have those devices. I think that'd be great, but I think we're not quite ready, I think, yet. So more discussion.
Absolutely. So I did want to, kind of catch your ear on this a little bit while we had a minute. I know, TOS has been supportive of the FDA approved incretin, therapies, the obesity management medications, the AOMs, the GLP-1 receptor agonists. That's, lots of the ways people are calling them. And I've had so many discussions with folks about what do we do about compounded versions. I know we're at an interesting time with FDA and the compounding pharmacies. So does TOS have a public statement or thoughts
Yes.
on that?
So uh, we have a statement, and it's fairly consistent with a number of other health-related organizations that we take a stand against compounding of these medications. And it's not that we're against compounding. I want to be clear. There's a role for compounding. Compounding can be a good thing for patients. It's the compounding of these agents that we have a concern about. So when there was a shortage, and now there is officially no longer a shortage of
Right.
either tirzepatide or semaglutide, according to the FDA. We patients wanted access, and that seemed reasonable. But the problem was, what's the purity of the underlying medication that these patients are getting? So the active ingredient is the key component. For compounding to be legal, they have to have active ingredient. Well, where are these companies getting their semaglutide and their tirzepatide? They're not getting the active ingredient because we know that the only companies in the world who actually make this are Novo Nordisk and Eli Lilly, and they're not selling their products to compounding pharmacies, right? So that means the compounding pharmacies are getting these from other places. They're not the same medication. So so from that perspective, that's our concern, is we don't know the efficacy of what's being used. We don't know the safety. And we took an oath as providers to do no harm, right? And so yeah, we want our patients to have access, but we don't want that in a situation where they could potentially be harmed. And it's not, and patients are spending a lot of money on these compounded versions. It's not like they're cheap. Yeah, they're cheaper than the
Right.
branded, but they're still very expensive. And and it's our concern that people are being taken advantage of,
Mhm.
because they're desperate for wanting to lose weight. And so there's definitely some concerns from that perspective. Again, I want to emphasize that we're not against compounding per se, and obviously there's a lot of legal stuff happening,
Mhm.
and don't want to get into that, but certainly um, one of our other concerns that we have about compounding of these substances, because they're coming at a lower price, doesn't incentivize our payers to pay for the FDA approved branded.
Mm.
And we're doing everything we can to get patients access, which means getting payers to pay for these treatments,
That's a
for
good point.
this disease, obesity, um, or for cardiovascular disease reduction, or for sleep apnea reduction. So I think that is another thing to consider that a lot of
Yeah.
people haven't talked about.
Another one that I, as a dietitian and someone who's been in this field for so long too, is that you tend to see, not always, but you tend to see some of the groups doing compounding not really have that full wraparound care, the comprehensive model,
Correct.
engaging. It's not just getting the medication; it's really all the other stuff. And we've
Right.
done this in bariatrics forever, and so I think now that we have medications that are able to produce, significant weight loss and change in body composition, we really do need all hands on deck from all the areas. And so I hope that we can get to where, at any place someone's getting that kind of a
Right.
treatment, that they're also able to get access to nutrition, behavior, exercise, physical activity support, and along with that, because even,
Absolutely.
I mean,
It's not just hand a prescription to
yeah,
somebody and see you later. And the amount of weight loss we see with these new treatments, we're talking 15, 20, 25% weight loss, not that dissimilar to metabolic bariatric surgery. That needs close observation. There can be elements of, where patients get so much weight loss that they have malnutrition and this and that, and they need that support, and we need to be following these patients closely. So that is, I think, another concern about,
yeah.
who's giving this to the patients, and are they certified in these areas?
Yeah, and that's, I think, too, where the professional organizations come in, and we've been, again, it's not. I sort of cringe every time we hear people say new medications, right? Because there's been medical treatment for a long time.
Right.
There's even been drugs in this class for a long time, but really, I think significant weight loss is the kind of that tipping point where we're saying, okay, well, this is now on everybody's radar. We do, we maybe didn't need to look at body composition if someone lost 10 pounds, right? But
Right.
maybe we didn't need, a special, team of people, but if someone's at a lower level of severity. But
Right.
as more and more people are experiencing this, I think they're going to experience what I did over the years of just, there's medication. I mean, especially with medication and insurance changes and drops and all of that, like, this is a long-term relapsing condition that people have forever. So even when they're in a good phase, that doesn't mean we drop them. I
Right.
think of that a lot like therapy, right? For some people, you go forever when things are good and when things are hard, and they're there as it's a support, right? So hopefully they are getting, those types of therapeutic, connections along the way.
Absolutely, and that's a key point. That obesity is a chronic disease, right? And it needs chronic therapy. It's not, oh, take a medicine for 3 months and then you're done. It doesn't work that way. We don't treat other chronic diseases that way, like diabetes, hypertension. we treat patients and we keep them on treatments, and we continue to treat them. But there's so much stigma associated with obesity and misunderstanding, that, oh, it's a choice. It's a, no, it's not a choice. It is a disease. And people need help, and we have great treatments. So, we're working on that.
I am worried a little that all this media attention and everybody, dinner party kind of conversations now that I've been in a bubble with obesity care specialists for so long and no one else knew what we did.
Yes.
But now everybody's asking, well, what is this? And, they get it wrong. And, when really smart people that I know are asking questions, and I'm like, that's how the general public is viewing this.
Yes.
We have so much work to do
Right.
from an education.
Although you could take it from the other side, is that there is talk.
Yeah.
At least people are talking about where they were before, right? We have there's more awareness. We see ads on TV now. We see, I think those are on the positive side, that the discussion is out there. We're have interviews of Oprah, and we have this and that.
We used to beg for that kind of attention to have
Right,
a platform
right.
to talk about it, for sure.
But there's a lot of misinformation out there, and I think people individualize it. They say, well, I don't have that problem, or well, yeah, but you didn't, people don't choose to have these issues, right?
But we're inching up on the majority of people having a struggle with their weight, with
Oh, yeah.
70%.
The majority have overweight
It's the
or
majority.
obesity. So soon we're going to be the majority have obesity.
Right.
Although, depending on how you define it.
Right. There you go. Well, I did want to make sure that we talk to folks about the Obesity Society's annual meeting this year. I know, gosh, we're just in spring, but soon it'll be the fall where we're busy, connecting with our colleagues again. So what do we have going on this year at the meeting to get excited about?
Obesity Week is our annual meeting for our society, and it's held usually in early November. And this year's meeting will be in Atlanta at the beginning of November. And the theme of the meeting will be about obesity as a disease, because that's, again, the theme of my presidency this year. And so there will be, sessions, whether they're keynote lectures or symposiums or workshops, about the mechanisms that lead to obesity, as a disease. And then it's a disease that causes complications. So we're going to have symposiums and sessions on the complications. So, for example, cardiovascular disease, Alzheimer's, cancer, kidney disease, fatty liver disease. Well, that's changed names over and over again. So there'll be sessions on those things directly. So there'll be science, but there'll also be direct clinical sessions, anywhere from pediatrics to how do we deal with obesity in older age individuals? How do we deal with people who had severe super obesity? There'll be a number of sessions, of course, on new treatments. There'll be abstracts presented of brand new trials, from industry on new treatments. So we're excited about those. So cutting edge science and clinical, and an opportunity to get together. We're talking 3,000-4,000 people coming together. It's a great opportunity to network and see old friends and colleagues. And Atlanta's is a fun, bustling city, so a lot going on. So join us. We'll be there. And I look forward.
Well, we can road trip down there with some of our Charleston people, maybe.
That's right. Well, from Charleston, you might as well drive, right? By the time you go to the airport and park and all that, you'd be there. But yeah, so.
I also think having the patient voice, you guys have done a really good job with that over the past few years. I'm always happy to see. I know this past year, that was really the keynote and the opening, and that kind of set the tone. I really always appreciate that.
Yeah, I'm glad you brought that up, because that was a highlight of last year's meeting, and not that we didn't do it before, but it was really something that we pushed for, and we're going to continue to do that. So we got nothing but positive feedback on that, and that's critical.
Yeah, great. Well, I'll have to connect with you here while we're here in town together. But I
Yes.
appreciate you so much for joining me and sharing kind of your thoughts and on behalf of the Obesity Society.
Right. Well, thank you so much for having me today. It was a pleasure.
All right, we'll see you soon.
All right. Bye.
Bye bye.